Hello everyone, in this video I'm going to be teaching you Weger's diagram. I'll be explaining how contraction, pressure, and depolarization occur within each other at the same time and how they're related. So I already have the diagram pulled up. I thought we should catch our bearings first because this diagram is quite busy. On the bottom we have seconds. This just shows that all of this occurs in less than 1 second. It's quite impressive. Above that we have ECG or EKG, which is electrical impulses of the heart. We've already gone over that before in the previous video, but that is still incorporated here. Above that we have left ventricular volume. Volume meaning blood volume, how much blood is being pooled into the left ventricle and how much would be exerted out of the heart. That is in milliliters. And then we have pressure in millimeters per mercury. That unit should be recognizable as that's the same unit as taking blood pressure. In that graph we have aortic, atrial, and ventricular pressures all within the same graph. I did my best to distinguish the three as they are quite overlapped. Aortic is purple, red is ventricular, and orange is arterial. Above that, we have different phases, 1 through 7. Those are listed below. We'll go into more detail about that later. And above the phases, we have shown that white areas on the graph are relaxation or diastolic, and the gray section in the middle is systolic, or that is where the contraction occurs. So let's start from the bottom. We have EKG, ECG. Like I've already said, this is electrical impulse of the heart. So before even the P wave, it would be a plateau here, and that would be the development of a contraction. We have the P wave, which is where the atrium contracts. That is where the SA node fires to cause the atrium to contract. That is seen on lead 1 from right arm to left arm, collecting negative to positive. We then have the plateau here, which is the AV nodal delay. We then go into Q to R. Q to R is the bundle branches going down the septum of the heart. This is all seen in lead 2 as it is going from the right arm to the left leg. Since it's parallel, we see that it's a big spike as that signal is being collected all at the positive. And then on the opposite end, from R to S, we have the Purkinje fibers, which is on the same lead, but the signal is being collected in the negative electrode. So it's going in the opposite direction as it is in the opposite direction of bundle branches to Purkinje fibers. We then have a plateau and go into the T wave, which is essentially where the ventricle will repolarize and relax. And then we have a long plateau until at the end we're able to see the beginning of the P wave. This occurs to everything in this graph as it is going to repeat itself. It's a continuous line and repetitive cycle. So we would see all of that again at the end here. It would repeat itself. Then we have volume. This is essentially stroke volume. How much blood is being put into the ventricle. So at this portion here, we have the atrium contracting at this point here. So we're thinking about volume. Let me draw you a potato. Let's think about this with a picture. So The SA node is, I'm also relating this to the EKG at the bottom. We're going to slowly pile it on top of each other. So the SA node fires. SA node fires. It's going to cause blood from the atrium to be pushed into the ventricle. So it's going to cause contraction, and it's going to push blood from the atrium to the ventricle. We're going to have a plateau as this portion, it's called isovolumetric contraction, where a contraction occurs in the heart, but the valves in the heart are all closed, so no blood is moving anywhere. So at this point in the graph, the end diastolic volume, that is where that is going to be where our left ventricle landmark here is going to end its relaxation phase and go into contraction systole. So the reason there is a huge dip here is because the left ventricle is contracting and causing blood to be pushed forcefully out into the aorta. The reason it's a drop is because this blood is leaving. It's leaving the ventricle, going to the aorta. So we're going to have a large dip down. We then, at this bottom point, have the end of systolic volume, and then we have a gradual increase here. This is because of passive filling. So remembering that the superior and inferior vena cava of the heart is going to bring blood into the right atrium. 80% of that blood is going to be passively filled into the right ventricle before the SA node fires and causes a contraction to push the rest of the blood into the ventricle. So that's what we see at that slow, gradual increase. And then, if you can see here, it's going to repeat itself. We're going to have that increase of the atrium contracting, and it's going to start all over again. If you think of ways that we can manipulate the volume graph through stroke volume, what we could do is we could increase the preload, which is the amount of blood that is going to fill the ventricle. If we increase that amount of blood, we're going to have a bigger spike there before we drop down into the ventricular systole. If you increase the afterload, meaning how much back pressure is against the aorta and how much pressure you have to overcome to push the blood from the left ventricle into the aorta, this is going to cause this long, gradual downward. It's going to make that shorter if you increase afterload. And this is if you increase preload. If you increase contractility, it's going to cause the end systolic volume to be much lower. It's going to cause it to go down much lower. Because you're not going to have as much blood after that contraction because you increase the contractility. You're not going to have as much blood sitting in your ventricle for residual. And then we have pressure in the graph. Before I go over these 3 lines, I wanted to give another anatomy review of the heart, just so that we're all familiar with what is going on, because this one involves a lot more of the anatomy of valves. So again, 4 quadrants, right, left atriums, right, left ventricles. So for the right atrium to the right ventricle, let's see. We have a valve here that separates the two. That is called the tricuspid valve. From the right ventricle to the pulmonary artery, we have the pulmonary valve, and then into the left atrium, separating the left atrium to the left ventricle, we have the bicuspid valve. This is also called the mitral valve. It goes by two names. Either one is correct. And then lastly, from the left ventricle out to the aorta, we have the aortic valve or semilunar valve. So quick refresher on that as we're talking about more valves related here, as you can see. So let us go over the atrium first. It has less aggressive action happening. So first we have, it's labeled as the A wave. Looking at all the graphs listed below, we see that the atrium is going to contract and the SA node is going to depolarize. So this A wave here, this little bump, is the atrium contracting. This landmark shows that the mitral valve is going to close. If we look at our anatomy graph, this is the one separating the left atrium to the left ventricle. So this is going to be closed. From this point, we have, this is called this section here, 2 from about 3, is called isovolumetric contraction. This means that there is a contraction in the heart, but all of the valves are closed. So no blood is being pushed or moved anywhere. This is going to cause an increase in pressure because of the contraction and it not going anywhere. So this can be seen especially in the ventricular pressure. This contraction is occurring and the valves are closed, so nothing is traveling anywhere. This is in the left ventricle here. At this point, nothing is happening in the atrium, in the aorta just yet. So there is a plateau only because of what's happened previously. But at this point, the aortic valve separating the left ventricle to the aorta is going to open. That is going to cause a huge spike in pressure in the aorta. So blood is going to violently rush into the aorta from the left ventricle. Because there is even still so much pressure in the left ventricle, we're still having an increase in pressure from the left ventricle along with the aorta. And even so, because there was so much pressure, we had a small blip in the atrium because of back pressure from the ventricle. Because of this valve here, it caused it to move into the atrium as back pressure from it pushed it up. So we're able to see that there. From this point, we have a gradual decrease as the amount of blood from the left ventricle is decreasing, which is what we see down here. There's less volume, so we're having less pressure going along with it, and for the ventricle, you just slowly decrease down. For the atrium, you're gradually coming back up because of filling from the superior and inferior vena cava, which is going to be correlated to passive filling over here, back in the volume. But for the aorta, you see that the aortic valve, which was open to the left ventricle, will close, and then it will taper off the pressure in the left ventricle, taper off the pressure in the aorta as it goes to the rest of the systemic circuit. And then the mitral valve is going to open again because it was closed. It's going to open and drop both ventricular and arterial pressures. And then this is going to happen again. As the A wave, it will repeat itself. So part 2 of this prompt goes into how atherosclerosis can affect all of Wigger's diagram. So let us first go over atherosclerosis. What this means is a buildup of plaque within coronary arteries that supply blood to the cardiac muscles of the heart so that it's able to pump. Because the heart in itself is an active muscle. It needs blood supply for itself to work. Plaque can build up through many different types of defects, such as a creation of a thrombus or embolism, or can be causes of myocardial infarction, ischemia, and overall it will decrease your cardiac output and can greatly affect your survival rate of a cardiac event. So your coronary arteries is what's feed your heart. It what's feeds it because it's a muscle in itself. So let me draw a quick diagram for you, as this is going to be a artery at a diverging point. So the cause of this is inflammation. What happens is that at a downstream branch, blood is going to be going down, and blood doesn't have a sense of direction, so oftentimes it's going to hit this branch and it can cause an inflammation response and cause clotting trauma from creating blood. So an immune and inflammatory response is going to come into this effect, as this is going to be plaque here and damage is occurring here. So what is happening within the lumen? This is our lumen here. And alongside this are basically, they're gap junctions, but it's what divides the lumen to the intima. So between these are gap junctions, which normally hold it tightly together, but it doesn't sit flush within the cell. So what we have here is small dense LDL. Small dense LDL is going to squeeze itself between these gap junctions, and it is going to oxidize. And it will become alpha LDL. This is not good. What will happen is a macrophage, which is a cell that eats other cells, will eat the alpha LDL, and this is a macrophage. So once this macrophage eats the alpha LDL, it's going to turn into a foam cell, which will actually push itself into the intima, and it's just going to build on top of each other. So this is a foam cell, and all this which is built on top of each other, causing a decrease in the lumen size, and this can be potentially a blockage. If there's a blockage in the lumen, that means there's going to be a decrease in blood volume. Blood is not going to be able to travel. Blood is not going to be able to feed the heart through the coronary artery, so it won't be able to work as hard as its lack of nutrients is subsidized. So if we go back to Wicker's diagram, we're definitely going to see it here as decreased in volume. For compensation of this, we're going to see a increase in heart rate and tachycardia, which we'll see in the electrical impulse in EKG. It's going to increase its rate of firing and contraction to help compensate for its lack of volume through the blockage from the foam cell. And we may also see there's going to be an increased amount of pressure because of the closed lumen. It's going to have to push the blood through the blockage, and it's going to just cause an increase in pressure in the lumen. There are pharmacology techniques that can be used to treat atherosclerosis. One includes ACE inhibitors. ACE stands for angiotensin converting enzyme. This cascade of reaction begins at the kidney, releases renin, which would then be converted to angiotensin 1. ACE is used to convert A1 into A2, but with this drug, it can stop the conversion from A1 to A2. Overall, it will decrease aldosterone levels and can in turn decrease blood pressure. We also have calcium blockers. It's in the name, but it blocks calcium. If you remember from the other video, calcium is imperative in contractility tissue with the millivolts, where this graph looked like this with the resting membrane potential, how sodium channels opened and closed. Potassium would leak at the top, and at this plateau, calcium would be triggered, and eventually calcium would open and reset this. Remember, this plateau was from the goldfish diagram. From the depolarization, calcium feeds the SR, holding all of that calcium to then be put into the cell, which would then go into the sarcomere and cause the contraction. So blocking calcium is going to essentially slow all of this process down. It will slow down the contraction tissue and inotropy. So all of this in turn will cause a decrease in chronotropy, which is the rate at which the SA node fires, meaning it's going to decrease the heart rate. And because we're decreasing heart rate, we're also going to decrease blood pressure because we're not pumping out as much blood. The amount of volume of blood we're not pumping out as much, so we are also going to be decreasing that as well. Another drug is beta blockers. Similar to calcium blockers, it will block beta receptors. We haven't necessarily talked about this yet, but beta blockers is inverted. It's from the sympathetic nervous system. sympathetic nervous system releases epinephrine and norepinephrine to cause excitatory responses. So these hormones would, or also neurotransmitter, would go into the heart and it would be received by beta 1 and beta 2 receptors. Once it's recepted, it would go into the heart and it would cause an increase in inotropy, which is contraction. We would have an increase in chronotropy and increase in dromotropy. But with the beta blockers, it's going to block, depending on which one, because there are selective and non-selective beta blockers. So it could only block one, or it could block both. And that way, less norepinephrine and epinephrine are going to be received into the heart. Therefore, we're going to have an opposite effect on all of these. And in turn, we're going to have a decreased heart rate and a decreased blood pressure because we're not being innervated by the sympathetic nervous system. We're having more so of peripheral nervous system actions. So through all of these different pharmacology drugs will decrease blood pressure and decrease heart rate, which can decrease the effects, the bad effects from atherosclerosis, which is going to affect the Wicker's diagram. Being more in this realm of normal for PNS will less likely affect these waves. So that concludes video 2, and thank you so much for watching.